Hi everyone, welcome back to Next Level Ophthalmology. Today we'll be continuing the topic of uveitis and it will be a short class regarding intermediate uveitis and posterior uveitis. So what is intermediate uveitis? It is the affection of the inflammation of the pars plana, which is shown by the diagram here. Okay, that is the amount of that is the area of uvea that is affected or inflamed in intermediate uveitis. So there is inflammation of the pars plana, peripheral retina and the base of retina with adjoining vitreous. So there will always be some amount of vitritis or inflammation of the vitreous. So what is the clinical course? It is usually a chronic relapsing kind of a disease. We never get acute intermediate uveitis. Okay. So it is a chronic disease which keeps relapsing and has an insidious onset. So what are the causes of intermediate uveitis? It can be associated with an infectious etiology or a non-infectious systemic disease. So the most common cause of infectious etiology in India is tuberculosis, followed by syphilis and Lyme's disease. The other common systemic illnesses that are associated with intermediate uveitis in India, it is more commonly sarcoid, followed by multiple sclerosis. So what are the clinical features? As I said, it is a insidious onset disease. So it can be unilateral or bilateral. Insidious onset of blurred vision, more of floaters. So these floaters are caused by the cells that are present in the vitreous. And when associated with cystoid macular edema, it can cause metamorphopsia. There is no anterior segment symptoms like pain or redness of the eye. Okay. So on examination, you might find some amount of anterior uveitis, which we say spillover, because there is some amount of inflammation of the anterior uvea as well. There can be mild cells and KPs. Sometimes you can see posterior synechiae when there is Lyme's disease. Most commonly, you will see cells and haze in the vitreous and peripheral periphlebitis. Phlebitis means inflammation of the veins. So you see inflammation along the periphery of the veins and which is seen as sheathing. Okay, and you have to do an indirect ophthalmoscopy to detect this. So the next feature is snow banking, that is presence of exudates along the base of the retina. More so inferiorly due to uh, gravitation of the exudates. So how do we grade vitreous haze? We have grading similar to cells and flare that we understood in anterior segment inflammation. So it depends on how easily the nerve fiber layer and the disc and the vessels are visible. So if you see a good view of the nerve fiber layer, there is zero haze. If you see the disc and the vessels clearly, but the NFL or the nerve fiber layer is a little hazy, then it is +1. If the disc and vessels are hazy, then it is +2. And only if the disc is visible through the haze, then it is +3. And when the disc is also not visible, we grade the vitreous haze as +4. So what are the complications? So complications can arise in intermediate uveitis and these are the common causes of decreased vision. So most common presenting feature of intermediate uveitis would be floaters, but whenever they have decreased vision, we should think of all these four causes. First one is cystoid macular edema, which is the most common cause of decreased vision, and then there is epiretinal membrane. Peripheral neovascularization and vitreous hemorrhage happens over a long period of time, and then there is formation of complicated cataract, which we can see in any form of uveitis. So how do we investigate? You should investigate based on the particular etiology that you are suspecting. Okay, so tuberculosis should be done in all cases of intermediate uveitis because in India it is the most common cause of infectious uveitis. Okay, syphilis is a great masquerader and it can present as any kind of uveitis. So, VDRL and TPHA and FDA antibodies are the various ways in which you can detect syphilis. Sarcoid, you suspect when usually the disease tends to be bilateral. If there is associated anterior segment tented synechiae or decrease the aqueous formation, or while looking at the fundus, if you see more of a predominantly vein associated periphlebitis, then you suspect sarcoidosis. Whereas multiple sclerosis, the exudates and the periphlebitis tends to be more in the superior part of the retina. In such cases, you will need to perform an MRI or a CSF analysis. So when you're suspecting Lyme's, you need to do an ELISA for Borrelia. So these are the common investigations that you will need to perform. A vast majority of them will still have no etiology detected. Let's take a question now. A 50-year-old lady presents with floaters of insidious onset, okay, for around 10 days. On examination using an indirect ophthalmoscope, the following image is seen. So this is an image of the peripheral retina, and these are the snowballs. So what is true about this case? The most common cause of blurred vision in this patient is disc edema. Wrong. We learned that the most common cause of blurred vision in a case of intermediate uveitis is cystoid macular edema. There is never an anterior chamber inflammation. This is also wrong. There can be associated anterior chamber reaction. Workup should include ruling out syphilis. Yes, syphilis can cause any sort of uveitis. It is treated using topical steroids. No, topical steroids have minimal role in intermediate uveitis. So how do we treat intermediate uveitis? Intermediate uveitis is treated more with systemic steroids, especially when you're suspecting a systemic etiology. If you have an underlying infectious etiology, you have to treat that first. So infectious etiology, so if suppose the patient is positive for MAN2 or quantiferon gold, or if you detect CSF, VDRL for syphilis, so they should be treated for that along with systemic steroids. Then periocular steroids are given especially when you are dealing with the unilateral disease, okay, because you don't want to have systemic side effects. So periocular steroids, especially if you have ruled out an infectious retinitis inside. Then systemic steroids, and if you think that the underlying disease tends to be more chronic, then add a systemic immunosuppressant. Especially these are helpful in sarcoid, not very useful in tuberculosis. Then the next line of treatment is cryotherapy of the peripheral retina to prevent neovascularization, and vitrectomy if all the measures fail. So how are periocular steroids administered? There are two main methods. More commonly what we use and what we have learned as students was PST, or posterior subtenon injection. So in the various ways in which drugs can be given to the eye, here is the subtenon, where the injection or the drug is delivered into the subtenon space. So after instilling topical proparacaine, a cotton tipped applicator is placed on the site where you have to give the subtenon injection. You load 40 mg per ml of triamcinolone acetonide and in a 2 ml syringe with a 25 gauge needle, and the patient is asked to look inferonasally and steadily. The needle is inserted in the superior temporal quadrant of the globe in the bulbar conjunctiva, with the needle advancing in a zigzag manner along the contour of the globe. So always withdraw to check for vascular entry and then inject the drug. So a newer and a safer method is inferior transseptal injection, where the drug is delivered into the periocular space, okay, through the orbital septum, just like you give a peribulbar block. So here the skin of the lower lid and the maxillary area is cleaned with spirit. 40 mg per ml of triamcinolone is loaded in a 2 ml syringe and 25 gauge needle is inserted. The patient is advised to maintain a straight gaze. Then through the skin of the lower lid at the junction of outer 1/3 and inner 2/3, the needle is inserted along the orbital floor. The orbital septum is pierced and the needle is moved slightly in a zigzag manner to avoid perforation of the sclera. Again, you have to check for a vascular entry while injecting the drug. So this is about intermediate uveitis. We discussed various morphological patterns in which posterior uveitis can occur, where retinitis and choroiditis are the most common features, most common types. So when the infection or the inflammation begins from the retina and then proceeds to the choroid, then we call it retinochoroiditis. Most common example is toxoplasma. And when the infection or the inflammation starts from the choroid and then proceeds towards the retina, it's called as chorioretinitis, and most common cause is TB. Okay. Retinal vasculitis is inflammation of the vessels of the retina and it is seen as sheathing. It can affect the arteries or veins or both. So most common cause of retinal vasculitis in India is again TB. Okay, so you will hear a lot of TB in these classes. And the last, not so common, is the neurouveitis, where you'll see more of a papillitis due to inflammation. Okay. So what are the causes of posterior uveitis? It can be infectious and non-infectious. These are very confusing if you do not understand the pattern of presentation. So once you get the pattern, it is very easy to decipher uveitis. So the infectious causes can be bacterial, viruses, fungi and spirochetes. Non-infectious include a host of autoimmune conditions, malignancies which can present as pseudo-uveitis, and a group of disorders called white dot syndromes. So the clinical features again are floaters and blurred vision, similar to intermediate uveitis, but the visual loss tends to be more profound. Okay. In cases of peripheral lesions, there may not be any visual symptoms at all. It might be detected during routine examination. So the other symptoms are metamorphopsia, micropsia, macropsia, and photopsia, and positive scotoma based on the location of the lesion. So whenever there is associated anterior chamber involvement, these patients can present with anterior uveitis. So how do we distinguish a retinitis from choroiditis based on how they appear? More often than not, when you say retinitis, we mean we are dealing with an infectious agent. Okay, so there is an infectious entity that is leading to retinitis. Choroiditis may not be always infectious, it can also be due to non-infectious causes. So, on examination while doing a fundoscopy, the lesion is usually a bright yellow-white lesion in the retina, and you do not see retinal vessels over it because the inflammation is within the retina. You might see hemorrhages surrounding the lesion, and it is commonly seen in viral etiology. You might see a scar in the nearby in the proximity to the lesion, which is suggestive of toxoplasma retinitis. Whereas choroid is deeper to the retina, so inflammation, deep dull yellow lesions are seen deep to the retina, and the course of vessels over it, the retinal vessels seem unaffected. The overlying retina is normal, and the hemorrhages are rarely seen. So, how do these heal? When retinitis heals, there is thinning or atrophy of the retina. When there is healing of choroid because of presence of RPE there is always pigment proliferation. So vitritis tends to be more common in retinitis and not very common in choroiditis. Vasculitis is also more common in retinitis and not so common in choroiditis. So this is how a picture of a retinitis looks. So this is a typical example of a CMB retinitis. You can see that the lesion is florid. It is yellow and the vessels over it are not seen. This is hemorrhages surrounding the lesions, and this is a typical appearance of a florid CMV retinitis. So this is how choroiditis lesions look. They are dull, deep. The retinal vessels are seen coursing well over it, and there is hardly any vitreous haze. So this is the main clinical difference between retinitis and choroiditis. There are a lot of infectious agents and non-infectious entities that can cause both of these. So from next class we will start infectious causes of retinitis starting right from bacterial, not retinitis, all infectious causes of uveitis starting from bacteria, viruses, fungi and so on. So it won't be very difficult for you to remember and understand uveitis. Till then, have a nice time.